It's a real pleasure to join you all this morning, and I thank the SMSNA for inviting me to present on this really interesting topic, supraphysiologic testosterone therapy. What do we actually know? I have no disclosures for this. So we have been trying to boost our testosterone since time immemorial. In the ancient times, we ground up bull testicles and drank them, hoping that something vital would be imparted upon us. In the 1920s, the unilateral vasectomy gained popularity to boost testosterone naturally. In the 1930s, we synthesized testosterone, and this could have been the renaissance of testosterone therapy. In the 1940s, we found out that testosterone has a link to prostate cancer. This made things less appealing in terms of boosting testosterone. And more recently, the T trials and the Traverse trials have given us moving the needle back towards safety and efficacy. So supraphysiologic is the first thing we have to deal with, and we have to decide, do we know what physiologic is, and do we really care in terms of testosterone therapy? Our guidelines tell us that low across the board is under 300 or 350, and the goal for therapy on testosterone is 450 to 600. You see here this study of men as they aged. We know overall testosterone levels decline as we age. So a young person's supraphysiologic would certainly be higher than an older person's. To possibly misquote one of my mentors, something he would say, our eyes get worse as we age, but no one says let's not use glasses because that's not natural, right? And I want us to think about that as we think about testosterone and what we're doing with it with physiology. Now is a critical time to ask these questions because we know that testosterone prescriptions have been rising, especially in young men. You'll see in the green and purple arrows. We know that younger men are more likely to use direct-to-consumer ways of getting testosterone. And in one study, about half of the DTC sites stated a goal testosterone of at least 1,000. And I think you will all agree that for most guys, 1,000 is going to be supraphysiologic. So when we think about what are the risks associated with it, I've listed concerns that you might have about boosting someone's testosterone really high. There's great evidence to support a saturation model for prostate tissue and testosterone. And we have to wonder, does that actually apply to other tissues in the body? And there's this confounder that many studies or many people who are using high doses of testosterone are also using anabolic steroids. And we don't want to get confused with those when we're thinking about what we actually know. So let's start with something that I think we can all agree on, what we know about low testosterone. We know that low testosterone is a real bummer, and we know that from ADT, right? We know that these are the host of side effects people get when they're on ADT and have truly low testosterone. Let's take that to now what we know about normal testosterone and normalizing testosterone. The Traverse trial recently showed us that testosterone therapy, using topical testosterone to boost people into that normal physiologic range, is very effective at resolving symptoms of hypogonadism and also does not increase the risk of major adverse cardiac events, even in men who are high risk. Now, if we look at pharmacokinetics of injectable testosterone, we know that even at a reasonable dose, that will get you at the end of the week to being in that normal range. In the 2 to 3 days after the injection, you're probably going to be above 1,000. So anyone in here who took their T-sip in the last 2 days to get ready for the conference, to get energized, you're probably cruising right around 1,000, and you yourself are a case study of what's happening with supraphysiologic levels. So again, what do we actually know? This group out of Harbor UCLA took 43 healthy men, and they said 2 groups, 1 placebo injection, 1 600 milligrams of testosterone enanthate. I suspect no one in here is prescribing that regularly at that dose. Within those groups, half of them exercised, half of them were told, please don't exercise, take the next 10 weeks off. They checked their mood to see, does testosterone, is that going to make them aggressive? It did not. There were no changes in their mood, their emotional stability, or angry behavior. And here it will come as no surprise to you on the far right that lots of testosterone plus exercise equals muscle mass, right? They gained in fat-free mass, triceps and quads, cross-sectional areas, as well as bench press and squatting strength. More interestingly, this group I put in the blue box, please don't exercise. Here's a bunch of testosterone. You will still make gains in all of these qualities. As a young man who exercises, this was very appealing to me, as you can imagine, reading about this data. Now, these authors went on to say, let's look at the dose response and the age response. So similar setup. 2 groups, young men, 18 to 35, older men, 60 to 75. They all got a weekly GnRH agonist to completely take out the HPG axis. They were given testosterone and nanthate at a 25 milligram dose. That was the not happy group. 50, 125, 300, and 600 once again. For 20 weeks, we're asked to not do any exercise, and these were trough levels they measured of testosterone. And as you can see here, there is a dose response and an age response to the change in serum testosterone. And in that higher group, you're getting up to very high testosterone levels there. Younger are in black and older are in the light gray. These are the same qualities they measured in the prior study. You can see that as the testosterone dose goes up, muscle mass increases, strength increases, fat-free mass increases, and fat decreases. And you can see this is both in young men and in older men. Now, in terms of the risk, so I just told you that higher doses mean you get more benefit from it. But of course, we want to know what are the risks of doing this. So in that older group, we saw that elevated hematocrit was present in 6 of those men out of 60. We saw that leg edema was present in 11 men, 6 of them in the high dose group. And so they actually stopped that group's therapy because of this edema and worrying about safety of that. Prostate cancer was diagnosed in 2 men. AST, ALT, and bilirubin showed no change, and creatinine showed a very insignificant change. You can see here with the graphs how the PSA, hemoglobin, and HDL changed over time as well. In the younger group, it was acne. Across the board acne, and I suspect the men on the high dose didn't care too much because they were making such great gains without even exercising. So in summary of what we know from these studies, we know that you find an increased testosterone bump in older men. I glazed over that a little bit earlier on, but at the same dose, the older men were having a much greater increase in their serum testosterone. We know that hematocrit is what's dose limiting in the older men. We know that young men have acne. We know that older men will have that boost in hematocrit, will develop edema possibly, and these authors said prostate cancer. I would put to you that 2 men out of 60 being diagnosed with prostate cancer in this study does not make a strong case for causation. They also said that 125 milligrams of enanthate a week seemed to be the perfect eugonadal dose. It gave people gains in muscle and strength increase, but it seemed to be a good balance of the adverse effects that they were measuring. So we are now leaving what we know about supraphysiologic testosterone, and I'm going off the books here. We're going to talk about what we know about the real world. This is a study out of the Netherlands looking at men who are undergoing a cycle of androgenic anabolic steroids, because as we talked about, many of the men who will use one will use the other as well. So what's actually happening out there? These were men who were saying, I'm going to do a cycle, I'm going to bring my own medications, and the author said, we will just test you and see what's happening. 13 weeks, 4 medications on average, about 900 milligrams testosterone equivalent based on all the things they were taking. Testosterone was the primary driver, and then a host of supplemental meds that we use in clinic ourselves. So does it work? Of course it does. The vast majority had increased muscle mass, increased strength, decreased fat. Were there side effects? A host of them. You'll see 58% testicular atrophy, 56% fluid retention, acne, agitation. We also found that the drugs were not labeled accurately. ALT, AST, and CK all rose slightly, and hypertension was present throughout the group. Echoes were performed on about a third of these guys, and what we saw was the left ventricular ejection fraction decreased by 5%. Most concerning, left ventricular compliance decreased. These changes all resolve by the end of the cycle, but again, if guys are going to be doing multiple cycles in their lives, this may help explain some of the long-term side effects that we see in this population. So to tie it all together, what do we actually know? We know that supraphysiologic testosterone is inherent in testosterone therapy. Your patients you're starting, they are living this, okay? And so we can't shy away from this being the reality. We need to avoid conflating this with data regarding anabolic use, because these two things are separate, though in the public's eye, they are often the same. We don't know the safe limit for testosterone, but I suspect it is likely higher than we think it is. And the upper saturation point, while we know the saturation point in the prostate, the upper saturation point for the muscles and other tissues is still unknown. Thank you.